All right. So thank you all for joining us. Um, John, could you advance the next slide, please? Thank you. So our learning objectives for this talk are we're going to analyze some patient risk factors that lead to cardiac thrombosis. We're then going to evaluate medical and interventional management of pediatric cardiac thromboses in the acute inpatient setting. And then we're going to discuss and appraise the use of direct oral anticoagulants and newer therapies for pediatric cardiac thrombosis in the inpatient setting. So everything kind of in the acute phase. The outline of our talk, we really do have the leading experts on this topic. We have Dr. Nadia Chaudhry Waterman, who's one of our esteemed cardiology fellows at the University of Colorado, and she's going to be doing a case presentation, The History of DOACs in Pediatrics. Dr. Christina Vanderplum from Boston Children's is going to talk about the use of apixaban in critically ill children. Dr. John Kim, one of the CI doctors at Children's Colorado, is going to talk about inpatient medical thrombosis. And we're going to follow up with Dr. Jesse Esch, who is one of the cardiac interventionalists at Boston Children's. So leading into our first talk, you can take it away, Nadia.
Perfect. Yes. Thank you for that introduction, Dr. Loy. But like she said, my name is Nadia Chaudhry Waterman. I'm a pediatric cardiology fellow at Children's Hospital of Colorado, and I am going to start us off by doing a few case presentations. So our first case is one of anticoagulation in severe Kawasaki disease. We have a 2-year-old previously healthy male who presented with fever, tachycardia, and hypotension consistent with septic shock. The patient was admitted to the PICU and required high-dose vasoactive support to maintain appropriate hemodynamics. Based on the history and laboratory values, the team suspected a diagnosis of severe Kawasaki disease. His echo showed decreased biventricular function, a thrombus in the RV apex, and large aneurysms in the proximal LAD and RCA. With these findings, the patient was started on a bivalrudin infusion for systemic anticoagulation and intended treatment for the RV apical thrombus. The goal PTTs that were targeted were 70 to 90 seconds. For the underlying diagnosis of Kawasaki disease, the patient was treated with IVIG and infliximab, and his vasoactive support was subsequently able to be weaned. A repeat echo after 2 days of anticoagulation showed resolution of the intracardiac thrombus. The patient was then transitioned to enoxaparin for ongoing anticoagulation therapy and transferred out of the PICU. Prior to discharge, an echocardiogram was performed again that showed persistence of large coronary aneurysms, and the patient was discharged on a DOAC and aspirin therapy. This image is from the 2017 AHA guidelines for the diagnosis, treatment, and long-term management of Kawasaki disease. As you can see, based on the fact that the patient had large aneurysms that were persistent, aspirin was indicated, and then anticoagulation with warfarin or low molecular weight heparin is also reasonably indicated. When this guideline was written, those were what was available for anticoagulation, but now that we are gaining more and more experience with DOACs, DOACs are another reasonable option in these patients. The next case is a case of bivalve being used for catheter-directed therapy. This is a 12-year-old female with fulminant myocarditis requiring VA ECMO support for cardiogenic shock and severe ventricular failure. She was found to have an LV apical thrombus despite ECMO anticoagulation with bivalve. In her case, a directed thrombolysis catheter was placed across the mitral valve via the atrial septum. The patient received a 1 milligram alteplase bolus followed by an infusion at 1 milligram per hour. After 12 hours of the alteplase infusion, the infusion was stopped. The LV clot was still present at this time, but the patient had had significant bleeding at her ECMO cannula sites. A bivalve infusion was maintained in the ECMO circuit, and the goal PTTs were 50 to 70 seconds. Following this, a secondary bivalve infusion was added via the directed lysis catheter that had previously been used for TPA. The bivalve in the lysis catheter was titrated to achieve a systemic goal PTT of 70 to 90 seconds. And the follow-up echocardiogram eventually showed resolution of the thrombus and continued improvement in the patient's function. Here we have echo images prior to the bivalve infusion and post. So in the top row, you can see that prior to the directed bivalve infusion, there was evidence of the LV apical thrombus, both in the four-chamber view on the left and then in a short axis view on the right. After the directed bivalve infusion, we see that there's no longer evidence of thrombus in the LV apex in the left-hand image. And then in the right-hand image, this is taken a little further up in the heart, but we can still see that there's no thrombus at the level of the mitral valve. And then our last case is a case of anticoagulation in a high-risk Fontan patient. This is a 3-year-old female with hypoplastic left heart syndrome, status post palliation completion with an extracardiac Fontan, whose postoperative course has been notable for hypoxemia. On post-op day 0, there were no initial complications, and the patient progressed as expected. By post-op day 4, the patient started having issues having labs drawn from her right upper extremity PICC line. Ultrasound on that day showed a catheter-associated VTE, and the patient was started on enoxaparin. The following day, the patient had persistent hypoxemia to the low 80s, and an echocardiogram showed narrowing of the IVC anastomosis and significant clot throughout the Fontan circuit. That same day, the patient was switched from enoxaparin to bivalve for systemic anticoagulation, targeting PTTs of 70 to 90 seconds. 2 days later, her echocardiogram showed persistent clot in the Fontan circuit despite 48 hours of therapeutic PTT levels, and therefore the patient was taken to the cath lab for thrombectomy. Following thrombectomy, the patient was maintained on bivalve for 5 more days before transitioning to a DOAC. Here we have angiograms from the catheterization lab prior to thrombectomy or any other intervention. On the left-hand side, we can see a contrast injection into the superior portion of the Fontan, and on the right-hand side, we see contrast injection into the inferior portion, showing that the two do not connect due to a filling defect where the clot is. Following intervention and stent placement at the IVC Fontan junction, we see that there's flow throughout the entire Fontan circuit. Next, I'm going to talk a little bit about the history of direct oral anticoagulants in children. So direct oral anticoagulants were initially called novel oral anticoagulants, but now that they are not so novel, the name has been changed to direct. There are 2 mechanisms of action for DOACs. Some work directly via 10A inhibition, and those include rivaroxaban, apixaban, edoxaban, and betrixaban. Others work via direct thrombin inhibition, similar to bivalve, and that includes dabigatran. In terms of the background of DOACs, the first direct oral anticoagulant drug that was FDA approved was in 2010, and that was dabigatran, which was approved for stroke prevention in adults with atrial fibrillation. Following that, rivaroxaban was approved in 2011, apixaban in 2012, and edoxaban in 2015, all for atrial fibrillation. Eventually, all were approved for treatment of adult VTE, but betrixaban is the only one that is approved for prophy only, not treatment. Focusing back on DOACs in children, the first ones to be studied were rivaroxaban, dabigatran, and apixaban. These were first initially studied in patients without congenital heart disease. The Einstein Jr. study looking at rivaroxaban and the Diversity study looking at dabigatran showed non-inferior treatment when compared to heparin or vitamin K antagonists. They also showed a similar safety profile without serious bleeding events, and thus both the drugs were FDA approved for VTE in children in 2021. The Prevapix ALL study compared apixaban versus no anticoagulation for the prevention of VTE in high-risk ALL patients. This study found no significant treatment benefit, but secondary analysis demonstrated reduced VTE in obese patients with ALL. Major bleeding was infrequent in both groups, but there was more epistaxis in those on apixaban. Then, looking at studies that were done in patients with congenital heart disease, we have three to discuss. The first was the Universe study, which was a multi-center randomized control trial that was a two-part open-label study of rivaroxaban versus aspirin in Fontan patients. 112 patients were randomized 2-to-1 over 35 sites in 10 different countries, and all patients included were Fontans. This study showed similar safety profile and fewer thrombotic events in those on rivaroxaban. The Ennoble 8 trial was another multi-center randomized control trial, open label phase 3 study of edoxaban versus standard of care anticoagulation. This study included 168 patients randomized 2-to-1 over 48 sites in 14 different countries. 44% of the patients were Fontans, 22% were patients with Kawasaki disease, 4% with heart failure, and 30% other cardiac disease. This study showed a lower rate of clinically relevant bleeding and thrombotic events in those on edoxaban. And lastly, the saxophone study was another multi-center randomized control trial, an open label phase 2 study of apixaban versus standard of care anticoagulation that included 192 patients randomized 2-to-1 over 33 sites in 12 countries. 74% of these patients were single ventricle patients, 14% were Kawasaki disease, and 12% had other cardiac disease. And this study also showed a lower rate of bleeding and no thrombotic events in those on apixaban. With these studies in mind, especially the Universe study and the ones talked about on the previous slide, the FDA approved rivaroxaban for VTE treatment and Fontan prophylaxis in 2021.
Thank you so much, Nadia, for providing that really comprehensive overview of how DOACs have kind of established more of a mainstay in terms of pediatric thromboprophylaxis. And I want to talk a little bit more about now what's its clinical use. And I think when we start using any new medications, there's always this risk. But could this potentially also be a revolution for our pediatric patients, many of whom require some of these medications chronically? And so having the ease of a medication that not only demonstrates good safety and efficacy, but also has increased convenience is, of course, of paramount importance to our population. So when we started looking at these medications, there were kind of four key considerations. First, starting with efficacy. We ultimately wanted to determine that do DOACs effectively prevent and or treat thrombosis across various anatomical locations and patient populations. And this is, of course, followed by safety. Is how does the bleeding risk and overall safety profile of DOACs compare to the standard anticoagulation therapies? And I think we answer these two questions through a lot of the trials that have been discussed previously. The one limitation of those trials, however, is that we don't necessarily include the patient populations that are potentially more high risk, those with hepatic or renal dysfunction, those who are on additional medications, many that would generally be precluded from trials because of the concomitant use of those medications. We also don't necessarily take into effect what is the cost of these medications in comparison to standard of care. For those who manage patients on warfarin, you all know that warfarin is generally a very cheap and inexpensive medication, but some of the monitoring strategies surrounding it, be it point of care INR tests or needing to go to the lab for frequent phlebotomy, are not just a cost to the family, but also a significant inconvenience. And so I end with inconvenience, not because it's kind of the last consideration, because for many of our patients, this is perhaps one of the most important considerations, followed by whether it works and whether it's safe, is do DOACs offer advantages in terms of drug availability? Meaning, could you go to any pharmacy in any country conceivably and have access to the medication? Is it convenient in terms of administration? And for anybody who's tried to administer Lovenox to a 4-year-old, having any oral alternative is obviously hugely advantageous. And then is it convenient in terms of its monitoring and overall management compared to standard of care anticoagulants? And so with that, I think it's important to appreciate a little bit of the terminology that we so frequently use in our day-to-day practice, be it standard of care versus FDA-labeled drugs. And I think this is of paramount importance to understand these key differences, especially in pediatrics, where so much of what we do has not necessarily been evaluated specifically in those patients for that indication. And so much of what we do, we kind of quote unquote say it's off-label use, but at the same time, it's also our standard of care. So the term standard of care is actually more of a legal term, and it denotes the level and type of care an average prudent healthcare provider with similar training would offer under comparable circumstances. And so the standard of care is determined by clinical guidelines, expert consensus, and real-world medical practice, which may include off-label drug use. This is important to appreciate when we're trying to get insurance coverage for many of these medications. And I think early on, many people struggled getting DOACs approved for pediatric usage because it was neither FDA labeled for that indication and population, and it had not yet achieved enough prevalence in the general population to be considered standard of care. But through these types of, further studies, as well as just kind of incorporating it into clinical practice guidelines and things like that, we establish its place as a standard of care medication. This is compared to the FDA labeled drugs for pediatrics. And while this is by no means an accurate Venn diagram, you can appreciate that I think much of what we do in terms of pediatric medical and devices is more under the auspice of standard of care versus actually FDA labeled. And specifically for anticoagulants are warfarin, Lovenox, heparin. Those are all kind of our mainstay anticoagulant medications, but interestingly, they actually don't have labeling for use in pediatrics. And now kind of the new kids on the block are apixaban, bivalirudin, argatroban that similarly do not have pediatric specific labeling, but are becoming more frequently used, especially in cardiac ICUs. And then in terms of FDA labeled anticoagulants for pediatrics, we have dalteparin, which is a low molecular weight heparin, which I think personally I haven't used as much here in North America, in the US, but we used in Canada, not infrequently. And then dabigatran as kind of the primary DOAC, but once again, is not a clinically frequently used medication in comparison to rivaroxaban and apixaban. And so right now, rivaroxaban holds the only place where it's an FDA-labeled medication that's also used as standard of care for that labeled indication. Why is it so important to understand this? I think it's important because while randomized controlled trials and all the things that Nadia discussed are really important to inform FDA labeling, the true driver of standard of care is really the integration of real-world data, clinical experience, expert consensus, and the evolving needs of our patient populations. And I think as we start to use DOACs more and more, we've come to realize that there are different populations who may benefit from this, but these are also populations that are generally considered much higher risk. An example of this is the labeling of DOACs in terms of monitoring and dose titration. And so when DOACs first received its labeling, it did not require any level-based titration because many of the early randomized controlled trials demonstrated a very broad therapeutic window with the fixed dosing that was established based on their PK and PD data that ensured pretty good efficacy and safety across a broad range of patient sizes and dosing. However, what we realize is that this only applies to select patient populations that were initially evaluated in these trials and for the specific indications. And so when we're starting to apply these to potentially higher risk groups, such as children or those with complex conditions, or even early postoperative patients in ICUs, the role of DOAC levels may offer a significant benefit in allowing us to safely apply these novel therapies to higher risk populations. So what is the potential role of DOACs levels in children? Well, firstly, I think it's to assess drug-drug interactions that may impact DOAC blood levels. While DOACs have far fewer drug-drug interactions as compared to vitamin K antagonists, we do know that CYP3A4 and P-glycoprotein medications can alter apixaban levels. And the reality is that many of these medications are used frequently in our cardiac and ICU populations, including diltiazem, amiodarone, many antimicrobials like rifampin, as well as antiepileptics. And if these patients had been in a trial, those patients would fundamentally be excluded or would not be included if they had to be on these concomitant medications. But in real life, I think there is sometimes oversight where people just don't appreciate that these drug-drug interactions always apply. And so having these levels help you identify these other medications that may potentially impact, either increase or decrease the efficacy of this medication. I think it also has an important role in identifying the need of reversal agents. In speaking with many of my ICU and surgical colleagues, one of the biggest concerns initially with the use of apixaban was, well, what happens? We have to go to the OR emergently. What happens if patient goes to need a transplant? How are we going to get rid of its effect? And I think we've become comfortable with knowing when to hold Lovenox, how to reverse or bridge patients with warfarin. And we ultimately just have to get comfortable with understanding what's the clearance, both, based on their pharmacokinetics and half-life, but also kind of what's the clinical impact of having some residual apixaban and rivaroxaban when you're going to the OR for invasive procedure. So we do get apixaban levels in patients who present with any type of bleeding or who need to go for any surgical procedure to really see how much of the bleeding is actually attributed to the medication and or whether a reversal agent is truly indicated based on how we've held doses prior to that planned procedure. I think DOAC levels play a role in assessing compliance because a drug only works if you take it. And then lastly, to improve the safety and by identifying kind of what's the optimal therapeutic range that's also going to optimize efficacy as we try to apply this medication to higher risk populations like mechanical valves or patients with genetic thrombophilic conditions, such as antiphospholipid or factor V Leiden. So what are we exactly monitoring with DOAC levels? The reality is that these DOACs, primarily rivaroxaban and apixaban, as Nadia went through, are anti-10A or act on factor 10A. And so while they do show some impact on our baseline coags, such as PT, INR, PTT, and ACT, it's all generally quite minimal. And not necessarily predictive enough to actually titrate the medication to. So the most impactful of our potential monitoring is related to anti-10A. Now, because apixaban is one of the most commonly used anticoagulants worldwide, they have developed chromogenic anti-factor 10A assays that have a nomogram that go to kind of an estimated or a correlated concentration of apixaban. And so we call these an apixaban level. Now, they're not truly measuring the concentration of apixaban in the bloodstream. Rather, it's a chromogenic anti-factor 10A or just a standard low molecular weight heparin or heparin level. But that it reports it out as an apixaban level ranging anywhere from 40 or less than 40 to upwards of 320. And based on the Aristotle trial, which was a trial examining the use of apixaban for non-valvular AF, they created kind of these different therapeutic ranges, be it prophylactic, standard treatment, or high-risk thrombosis. And early on when we started using apixaban, I was obviously worried about using this in a population that could potentially be at risk of bleeding, as well as thrombotic complications. And so we started measuring levels, as well as initially anti-10A levels, just to see what were the dose response effect when we made adjustments, and what was the variation in these levels. And we found that generally speaking, patients would coalesce to these kind of three groups based on our dosing. And that for high-risk thrombosis indications, such as Kawasaki disease with giant coronary aneurysms, we would increase their dose and get them to these ranges with minimal adverse events. Now, with these chromogenic anti-factor 10A levels, they're not always readily available in all centers. They are readily available at most outpatient labs, but in its place, you can do a standard anti-10A assay, acknowledging the fact that these DOACs will prolong the anti-10A more than you would see with Lovenox or with heparin, such that for prophylaxis, our correlation was to an anti-10A of 0.5 to 1. And for standard treatment, it was 1 to 1.5. And if you were trying to achieve high apixaben levels, then your anti-10A assay was greater than 1.5. So a little bit about these target ranges. I have to admit that this is still a process that's evolving as we gain more data on the correlation of levels to both thrombotic and bleeding events. And when we compare this to INRs, for example, or anti-10A levels associated with Lovenox, the reality is that we've come up with these ranges based on understanding what is the rate of thrombotic and bleeding events with each of these different ranges. And so at this point at Boston Children's, we've created these three groups of risk, both the risk of thrombosis and the risk of bleeding. And so we place these patients into three groups based on their underlying patient-specific risk factors for bleeding and thrombosis, such as other underlying acquired or inherited thrombophilic conditions, past history of thrombosis. We also examine what's their indication for use of the antithrombosis agent, and then other pertinent clinical factors such as acute inflammation or infection, recent infections, recent bleeding events, and what type of instrumentation or artificial material that may be provoking for further thrombosis. Based on that assessment, we create kind of a personalized risk of, are they low risk thrombosis, standard risk thrombosis and bleeding, or high risk thrombosis. And we've made this kind of akin to what an INR would be. So for patients in whom you would have kind of an INR of 1.5 to 2, we generally try to target an apixaben level of around 80 to 150. For standard risk, which would be similar to an INR of 2 to 3, we would target an apixaben level of 100 to 200. And for high-risk thrombosis, such as those with an arterial thrombosis, threatened limb, or for select mechanical mitral valves or Kawasaki disease with giant coronary aneurysms with thrombosis, we would target in that population VKAs with an INR of 2.5 to 3.5, and this would be similar to an apixaben level of 200 to 320. But fundamentally, these have not yet been validated, and ongoing validation studies are happening. What's our current real-world usage of DOACs in children? At Boston Children's Hospital, I would say it's one of our primary anticoagulants used, and we've used it in over 1,100 children aged 3 days to 18 years, and a multitude, a few hundred adult congenital patients who we also follow as well. Some of the primary indications include both treatment and prevention of venous thrombosis, as well as treatment of pulmonary embolisms. We've used it for primary treatment of arterial thrombosis and intracardiac thrombosis. And when we've evaluated clot reduction or resolution, we found that over 96% of clots will reduce or resolve by 6 weeks. We've treated for both primary as well as secondary Kawasaki disease with giant coronary aneurysms. And what I mean by primary and secondary is for a select group, we transitioned from either vitamin K antagonist or low molecular weight heparin, or after a 3-month period of being on low molecular weight heparin. But we've also used it with acute KD, we've used it as the primary anticoagulant after transitioning from bivalirudin. We use it for post-surgical thromboprophylaxis with a variety of different indications, including bioprosthetic valves, post-Fontan procedures, anybody who has extensive patch material that worries the surgeons, shunts, RV to PA conduits. For non-cardiac indications, we've treated complete sinus venous thrombosis and or embolic strokes related to arterial dissections. And then we have kind of an emerging and expanding population of high-risk patients who historically would not be treated with DOACs, including VAD patients, as well as mechanical valve patients who have either failed standard therapy with vitamin K antagonists, or who, for a variety of other reasons, just could not tolerate being on a VKA or low molecular weight heparin. Some considerations for using DOAC, specifically apixaben, in the unit is that I generally say to kind of consider the same considerations you would for Lovenox. The half-life of apixaban is a little bit longer than with Lovenox. Half-life of Lovenox is around 4.5 to 7 hours, which is similar to that of rivaroxaban, but the apixaban half-life is around 12 hours. That said, your general principles for starting and holding Lovenox should apply similarly to that of apixaban. So once hemostasis is achieved, you have no active bleeding and no coagulopathy. We hold the AM dose if we're going to remove an RA, LA, or PA line, a chest tube, or pacing wires. We do not hold it for PIC or central venous placement or removal. We may hold the AM dose for a hemodynamic cap. But we will hold 2 doses if it's an interventional cath or if larger sheaths will be placed. We hold 3 doses for transhepatic access or any invasive cardiovascular or general surgeries. And we have many patients who are on apixaban for their thromboprophylaxis while listed for transplant, and this has caused a lot of questions from other centers of, well, how do you address it when you're going for a heart transplant? And generally speaking, we have upwards of 8 to 12 hours or more prior to a heart transplant so that we can easily hold 1 to 2 doses and sometimes even 3 doses. This is where having the levels are useful because we generally don't have our patients listed for transplant on the most highest range of the therapeutic range for apixaban. And so by holding 1 to 2 doses, most of our patients' apixaban levels going into the OR are less than 60, and we have not seen any increased surgical bleeding related to the apixaban. We had a fellow a few years ago examine this specifically for our waitlist patients, and most recently we've had our cardiac anesthesia staff do another analysis that's going to come out in publication shortly that just looked at all surgical patients who had been on apixaban pre-op to see if there was any increase in bleeding, and fortunately there has not been. So to answer the question of whether this is a revolution or a risk, I think the reality is that DOACs will become the standard of care in pediatrics for a variety of indications. But I do feel that the success of vitamin K antagonists in high-risk populations was really due to the personalized level dosing. And so for that reason, I think the success of DOACs may also lie in personalized level-based dosing. And we have to acquire this data and understand what are the, therapeutic targets that is going to optimize efficacy and safety for our high-risk populations to make it a success. John and I will say frequently that, part of our job is not just titrating a medication up and down. Because anticoagulation is just one component of preventing clotting and bleeding complications. But more importantly is identifying and defining patients who are at risk of clotting and bleeding. And we can't just do this with labs alone. Understanding the risk and the therapeutic intervention is a really dynamic process, especially in the ICUs. And so similar to a fluid balance, which we expertly define on a day-by-day basis, saying we want this patient to be plus 100, minus 100, and we incorporate our clinical exam, our creatinine, our BUN, our CVPs into making that assessment, we need to do the same for the cardiohematological assessment, where we say, we look at the labs, we look at the clinical picture, and we determine our therapeutic target for anticoagulation for that day, because their hematological system is just as dynamic as any other system in their body. And so I think this helps define this kind of different or emerging field of cardiohematology.
Thanks, Christina. We will segue. It's a perfect segue, as usual, to talk about use of bivalirudin as an infusion for treatment of more acute and critical thrombosis. So Christina, I think, did a very nice job describing how the use of DOACs can be introduced and utilized effectively in the inpatient space and in the ICU, but oftentimes we're going to need more intensive therapy with things like bivalirudin or other infusions. Bivalirudin has had a gradual emergence for the treatment of pediatric thrombosis. It in itself, just to reorient you, is a synthetic analog of a naturally occurring drug called hirudin, which is found in the saliva of medicinal leeches. It was first studied for use as an anticoagulant in the early 1990s, resulting in FDA approval for use in adults in 2000. As we've alluded to, bivalirudin is a direct thrombin inhibitor, whereas heparin is an indirect thrombin and 10A inhibitor that works via antithrombin as a cofactor. And its therapeutic effect is impacted dramatically by deficiencies in antithrombin. Bivalirudin, on the other hand, again binds thrombin directly and does not require a cofactor. And importantly, thrombin plays a pivotal role at the terminal stage of the amplified coagulation cascade for hemostasis and thrombosis. And bivalirudin that acts and inhibits that terminal step in the coagulation cascade both works on soluble and fibrin or clot-bound thrombin, thus resulting in a theoretic benefit of actual clot dissolution and thrombolysis. Some other advantages and details regarding bivalirudin as an infusion. Its metabolism is predominantly by proteolysis within the bloodstream, with 80% of it being broken down within the bloodstream itself and 20% renal clearance. And therefore, it can be used in both liver and renal injury, which of course is particularly relevant for our patients in the ICUs. It has an immediate onset and a very short half-life, even shorter than that of heparin. The half-life is 20 minutes, and most studies and clinical experience demonstrate that coagulation times normalize within about an hour after stopping the infusion. So its use in pediatric critical care has grown rapidly over the last couple of decades. The earliest reports for use in thrombosis were in the late 2000s by Guy Young and his colleagues. Looking at small single center dose finding and efficacy studies in children, which then eventually led to the Unblock trial in 2015, which is a randomized control trial and a dose finding trial for use of bivalirudin for treatment of deep vein thrombosis in children. Simultaneously, around that time, the use of bivalirudin in both ECMO and VAD were emerging with growing experience in individual centers, which eventually led to the development and the work of the Action Network, which of course Christina is one of the founding members of. And because of that, the use of bivalirudin in pediatric VAD is now essentially standard of care throughout throughout North America and some of Europe as well too. And with the use of bivalirudin, the Action Network was able to demonstrate a 44% reduction in stroke in these Berlin heart VAD-supported patients compared to the prior time before bivalirudin use. As a consequence, and in relation to that, it continues to emerge as the primary anticoagulant in pediatric ECMO. At many centers, it is the sole and initial anticoagulant, though some heparin use exists. And most recently, the PEACE Collaborative, the Pediatric ECMO Anticoagulation Collaborative, released a consensus statement last year and did acknowledge that bivalirudin is a reasonable choice for primary anticoagulation in ECMO. So this is a big step forward in pediatric use for bivalirudin in mechanical circulatory support. And it's with all of these steps over the last couple of decades and with a lot of focus on mechanical circulatory support, but bivalirudin is now re-emerging for primary therapy in pediatric thrombosis. Despite the work being done in the early 2000s and the Unblock trial in 2015, its use really didn't take off until the growing experience in mechanical circulatory support. So, of course, we all know our patients have numerous risk factors for thrombosis, particularly cardiac thrombosis, and can occur both in association with cardiac surgery and in the general critical care setting, with the examples that Nadia gave in her case presentations. So I'll show you a real-life depiction of what thrombosis looks like in pediatric critical care. This actually is an alpine bike race. I stole this somewhere from Twitter, and I don't even remember where I got it from, but you can see now the central line has been placed. The vascular architecture has been altered, and there starts to be some inflammation, and thrombosis is initiating. The platelets are just grabbing onto each other and being activated, and there's mass chaos at the site of thrombosis. You can see how any patient in our ICUs can be subject to this, both with all of the components of Virchow's triad with hypercoagulability, venous stasis, and endothelial dysfunction. Of course, a lot of our patients are inflamed, and you can see the inflammation has affected even the upstream platelets. They're just falling over just on their own without even being interrupted. And these risk factors that we see in the ICUs amplify each other and multiply the risk of thrombosis with each additional risk factor that gets added. So why bivalirudin and not just heparin? Most of us would say, well, heparin works just fine. We know how to use it. It ain't broke, so why fix it? But I would think actually most of us who have a growing experience with bivalirudin would say actually heparin probably was not working and it probably was not fine, and we probably did not know how to use it. But I think our experience with bivalirudin has allowed us to become more specified and directive with our therapy, much like what Christine described with level-based therapy with DOACs. So heparin, of course, has some benefits with a nearly immediate onset and short half-life. We have standardized laboratory monitoring with anti-factor 10A levels, and it is cheap. However, it does have some limitations. Remember that it depends on antithrombin as a cofactor. Neonates have relative antithrombin deficiency at birth, and antithrombin doesn't achieve normal levels until about 6 to 12 weeks of age. Inflammation results in consumption of antithrombin, and then liver dysfunction can result in decreased antithrombin production. So you can see how that affects all of our patients in the ICUs. Heparin, of course, also binds many plasma proteins that are increased in production with infection, and critical illness. And those heparin binding proteins can decrease the efficacy of heparin as a drug. So how does bivalirudin compare? It too also has a nearly immediate onset and a very short half-life of 20 minutes. PTT is the accepted primary monitoring laboratory test for bivalirudin, but I'll show you how more than just the PTT can be utilized to understand the drug. It is more expensive than heparin, but the cost of bivalirudin has declined rapidly over the last couple of years. And again, I'll remind everyone that bivalirudin can neutralize both fibrin or clot-bound thrombin, in addition to circulating thrombin, which is a big difference to that of heparin. The old adage is that heparin does not cause thrombolysis or treat the clot, it just prevents clot progression, whereas bivalirudin can, I have to say, theoretically treat and induce thrombolysis, but those of us who use it a lot have seen it actually melt the clots away. So let's go back to some of Nadia's cases and examples. So the first was a child with what we like to call Kawasaki, presenting with RV thrombosis in addition to the coronary aneurysms. Why does this occur? The patient had severe right ventricular dysfunction and blood stasis, which was amplified by the severe inflammation of Kawasaki in the shock state. The acute ventricular thrombus was a relatively fresh clot, underwent rapid thrombolysis due to the clot-bound thrombin inhibition with bivalirudin with rapid resolution. In the second case, she reported a patient with LV thrombosis due to acute fulminant myocarditis requiring ECMO. Remembering that the ECMO bivalirudin infusion is not delivered to the dysfunctional ventricle at appreciable levels because the infusion through the circuit is delivered directly to the arterial outflow cannula. And remember, in that instance, remembering that bivalirudin is degraded by blood proteases, the left ventricle will be the last area of the circulation reached by bivalirudin in a patient like this on VA ECMO. So placement of a lysis catheter allowed for direct delivery of bivalirudin to the clot to induce neutralization of that clot-bound thrombin and eventual thrombolysis. And in the third case, she presented a case of a Fontan patient who was immediately post-op and therefore at risk for some bleeding with catheter-associated VT with progressing to Fontan thrombosis. The bivalirudin infusion initially had the benefit of rapid onset and rapid clearance in a patient immediately post-op who was at risk for bleeding and who might need further intervention. And heparin infusions, remembering that they often require bolus doses to achieve therapeutic anticoagulation. Thus, those boluses add to the risk of postoperative bleeding. Some other potential uses for bivalirudin and its continued expansion include, in addition to ECMO and VAD anticoagulation, the treatment of cardiac thrombosis, the treatment of catheter-associated venous thrombosis, the treatment of pulmonary embolism. Thrombosis prevention is a new area where bivalirudin can and is used. We use it for thrombosis prevention in postoperative patients and patients who are peri-procedural. And then, of course, bivalirudin can also be used to bridge the drugs that are longer-term anticoagulants like warfarin, DOACs, or even Lovenox. So I'll take just the last couple minutes to show you how we use bivalent for the treatment of thrombosis at Children's Colorado. We don't use a bolus dose. We use fairly standard initiating doses with lower doses for older patients. The adult experience reports that the adult patients need almost a magnitude less bivalent to achieve the similar anticoagulant effects. And in patients with either renal impairment or those who are at high risk for bleeding, you can drop the dose by 0.05 milligrams per kilo at initiation and safely initiate the drug without achieving exorbitantly high levels. We choose targets based on the severity and acuity of thrombosis. Our prevention target is 50 to 70 seconds. The standard treatment target is 60 to 80 seconds. And then for severe and life-threatening thrombosis, we target a higher level of 70 to 90 seconds. Most formularies and references recommend a PTT target of 1.5 to 2 times baseline PTT. However, we and many other centers have simplified this by selecting a range of 50 to 90 seconds, irrespective of the baseline, which is equivalent to the 1.5 to 2 times PTT. We titrate based on a percent change of the infusion. And so the adage or the rule of thumb is that for each 10-second increase in PTT that is desired, you increase by 10% of the infusion. However, there is a limitation at lower doses of bivalent because the percent changes may have a lesser impact. I'm going to go quickly, Jesse, because we're taking up all of your time. We do also target within, as Christina alluded to us, within the spectrum of severity of thrombosis and bleeding, and we test with heparin neutralization with Hepzyme to avoid heparin contamination. However, we also do these other adjunctive laboratory testing to get a complete picture of the patient's hemostatic situation rather than just using the PTT. And so we've evaluated our local experience and plotted bivalent dose against each of these laboratory values and have shown acceptable correlation, with the strongest correlation being with the dilated thrombin time. And then finally, we use those laboratory data and have correlated them to the PTT and have been able to generate this table that shows the 95% confidence interval within each 10-second range of the PTT, so that you can expect to know where those other adjunctive laboratory data would land. And then with that, we have a diagnosis and treatment algorithm, which I'm happy to share to the audience since we're going to rush through this. And here are just some summary points from the rest of my talk.
Thanks, Dr. Kim. We got some time, so I will move quickly through my slides, so there's hopefully time for questions at the end. I work in the cardiac cath lab, and so my goal for this talk is really to give the general intensivist, especially, a little bit of frame of reference for thinking about when might you consider talking to your friendly neighborhood interventional cardiologist about trying to do some percutaneous intervention for clot. It's a big topic, and I don't want to get too bogged down in the weeds, but hopefully I can give you a little bit of a flavor for what's possible and what our toolkit looks like to trigger your brains if you're caring for a patient with thrombosis. And this is sort of an inspiration case. This is a really sad case that did not go well. This patient died. It was a previously healthy 15-year-old girl who'd had a couple of weeks of nonspecific chest pain and was seen in the PCP and the ED, and then came back with increased work of breathing. And eventually they twigged on to the thought that she might have PE. So sent her to the CT scanner for a spiral CT where she arrested. And after 110 minutes of CPR, she was eventually cannulated to ECMO and made it to our center. And sadly, by the time we got her to the cath lab to take this angio, which you can see shows massive PEs, completely occluding the right intermediate PA and the left lower PA, with additional clot in the left upper PA. She had really suffered profound end organ injury, and we weren't able to salvage her. John, can we go to the next slide? So she was sort of an inspiring case for me to try to learn a little bit more about cardiac thrombosis and how we could salvage the sickest patients. So if I'm thinking about what patients might come to the pediatric cath lab for management of clot, I mean, as you've heard, we've gained a lot of ground in terms of medical treatment, and certainly in my experience, bival is a pretty big game changer in terms of medical management of life-threatening thrombosis in the pediatric critical care and cardiac ICU populations. But certainly we see some thrombotic MIs. Fortunately, that's pretty rare in children. Pulmonary embolism, and they're really shifting indications about when those patients should be managed medically versus be treated with either surgical open thrombectomy or come to the cath lab for mechanical thrombectomy. Clot in the central veins is one that I like to draw your attention to. I definitely see this in both cardiac and non-cardiac patients. Definitely seen, for example, CDH babies who get SVC stenosis and then clot in the SVC and innominate vein, and that can have a pretty dramatic clinical impact, causing lymphatic hypertension, worsening their lung disease, and in extreme cases leading to chylothorax. Sometimes we just find or cause clots in the cath lab. And then, like so much of what we do in pediatrics, there's a really long tail of rare diagnoses that you're never going to list in a slide. But if you know a little bit what we can do in the cath lab and such a patient comes under your care, you might think to talk to us. So in terms of our toolkit, we kind of have mechanical tools. So we can use balloons to kind of smush the clot. Stent it up against the vessel wall to trap it. We can kind of pull it out with a basket type device. As you see in the upper left diagram there, that's a vascular basket that you open beyond the clot and then you pull it back, and it's like using a fishing net to kind of grab the clot and externalize it. More recently, we're getting wider availability of aspiration systems. The idea is here you're going to suck it out of the body, which intuitively is really appealing and is sort of what you would like to do, is get the clot out of the patient, but to do it without having to do an open procedure. And we'll talk a little bit about some of the tools available to us. Thrombolytics, as Dr. Kim said, you might think of bival a little bit on the gentle spectrum of thrombolytics, and then certainly TPA, either systemic, catheter-directed, or pulse, where I'm just actually pushing boluses of TPA directly into clot in the lab. Sometimes that can be quite effective, especially with fresh clot. And then there are these hybrid systems. This is on the right side of the diagram. At the top is the ecosystem. This uses it's a catheter that delivers TPA and also sends ultrasound pulse waves to kind of break up the clot at a microscopic level. And then below it is the angiojet system, which is a pharmacomechanical system that sends high velocity saline bouncing around to try to break up the clot, but does tend and also inject TPA. But it does tend to cause a lot of hemolysis, hemodilution, and blood loss. Both of those systems are pretty big and kind of have expensive capital outlays to have those systems in your hospital, which can make sense if you're an adult cath lab that's treating a lot of PEs, but is often the case on the pediatric side. It can be challenging to get your hands on those. Part of what this boils down to is that none of these tools are made for children. They're all made for adults. And as always, we're trying to beg, borrow, and steal to bring something to our smaller patients. So if I'm thinking about, can I use a tool for thrombectomy or thrombus management in a pediatric patient, I'm thinking about these 3 A's of availability. Do I have it in my center? If I don't have it in my cath lab, can I maybe borrow it from my IR friends a couple floors below me? I'm thinking about access. Is the patient large enough to accommodate the catheters, for example, to do an aspiration thrombectomy? As I'll show you, some of them are pretty big. And will they tolerate the anemia, the blood loss that I will cause with the aspiration thrombectomy? So that sometimes puts a limit on our ability to treat smaller patients because of the potential blood loss. The middle diagram on the bottom there is part of the Penumbra Indigo system, which is one of the aspiration thrombectomy systems I have access to and use quite a bit. And it's basically a vacuum attached to a catheter. So you're sucking blood and you're trying to suck clot, but as you're sucking the clot, you're also sucking just fresh blood out of the patient, and you're filling up that little canister, and those lines going up the canister are 100 ml marks. So you will pretty quickly lose 1 to 300 mLs of blood doing this aspiration thrombectomy. And for a small patient, that can be just completely limiting. Next slide, please. So I wanted to show you, this is a little bit the older school way of how we would do it, which is kind of mechanical thrombectomy in the lab, so ballooning and stenting. This was a 2-month-old. This patient had dilated cardiomyopathy and was transplanted and was found to have, in the setting of post-op chylothorax, extensive clot in the innominate vein and SVC stenosis. So the angio on the left is kind of at the start of the case, and you can see there's significant thrombus burden and stenosis in the SVC. There's a filling defect in the right innominate vein, and there's probably some stuff in the mid portion of the left innominate vein in relation to a PICC line that you can see entering from sort of left subclavian approach. So what we did is we did kind of old school stuff for this young patient because they're not going to tolerate the blood loss from a big aspiration thrombectomy. So on the right, you'll see what we got after we did some balloon angioplasty to break up the clots, and then we left a thrombolysis catheter and infused TPA for about 12 hours, brought the patient back to the lab, and this is the follow-up angio. So you can see it's quite a bit better. The thrombus burden is a lot less, although there's still clot present, especially in both innominate veins, and a big dangler down in the SVC that's contributing to SVC stenosis. So the next thing we do on the next slide, John, is we stent that SVC to kind of trap that clot and relieve the obstruction, relieve some of that stasis. And now we've got pretty brisk flow. There's still some clot there, especially in that right innominate vein. So this patient's going to be anticoagulated. But the last picture is at his 1-year post-transplant follow-up cath, where we can see that really all the thrombus has resolved. There's brisk flow of the innominate vein. The SVC looks great. And we kind of called that a win. Okay, let's go forward. So these are the new school tools. These are the aspiration catheters. So the Penumbra, the one I showed you that loses blood by the hundreds of mLs, is on the left. The nice thing about that is the catheters are really small. They can go down to like 5 French. In the middle, we have the FlowTriever system, much bigger catheters, but the blood can be reinfused through the sheath into the patient. But you're talking 16, 20, 24 French, so they effectively treat PEs in older patients. But for a baby, it's not going to be an option. And then the big Bertha is on the right, which is the angiovac, which is literally like a vacuum attached to an ECMO circuit. You can get tumors, you can get massive intracardiac thrombus out of the patient with this, but the flow is so high and the blood loss is so high, you have to reinfuse basically through a venous ECMO cannula, and you need multiple large bore access points. So again, this is really for the older patients. Let's go forward. Let's skip this one, John, because I'm running out of time. So this is a PE case, 10 years old. Patient had RV strain and RV dilation, RV hypertension, came to the cath lab, and you can see on that RPA angiogram, big filling defect in the right intermediate PA, extending up into the right upper lobe PA. And this patient had pulmonary hypertension. They were not shocky, but they were kind of on the borderline. So we decided to try penumbra thrombectomy. And then, John, if you can show the next angio, this is after sucking clot out with the penumbra. You can see much better flow down into that right lower lobe PA. There's still a clot in the superior segment branch there, but we were able to go in and get that out as well. We got the PA pressure down to normal, and this patient steered clear of shock and arrest. Okay, I'm going to stop there. I just wanted to give you a little bit of a flavor of what we can do in the cath lab for patients with clots. You got to think about it and talk to your interventional cardiology friends. And then we're always thinking about, do we have the tools available? Is the patient big enough that I can get access and put those catheters in place? And can they tolerate the anemia, the blood loss that I'm likely to induce? But sometimes we can make a big difference in the cath lab for these patients.
And I'll just conclude by sort of giving a reminder of the spectrum of antithrombotic therapy for cardiac thrombosis. So, of course, you can use DOACs for both prevention and prophylaxis in patients who are inpatient. Of course, that transitions to treatment with level-based therapy in critically ill patients. And for more intensive therapy, you can use bivalirudin for acute thrombosis treatment. And of course, for significant life-threatening thrombosis, there are a number of catheter-based treatments, both with thrombectomy and lysis that Dr. Ash demonstrated. And then again, you can transition to enoxaparin treatment. And then the patient, of course, does not always need to be discharged on subcutaneous injections and can be discharged on DOAC. I hope we can sort of show you the spectrum of what can be used and what is possible for treatment of cardiac thrombosis in children.
Thanks so much. I know we're over time a little bit. Maybe we have time for one question if anybody has one, and then thank you for everyone for staying on. Maybe
Hey
Yes.
guys,
Go ahead.
this
Hey,
is Kevin.
Kevin.
This is Kevin. Hey, how's it going? Sorry, I was waiting. This is something that's always kind of bothered me with bivalve versus heparin. I love bivalve, but we monitor heparin and bivalve so completely differently, with like the 10A level less corresponding to like the patient's coagulant status and more with like a heparin level. And then bivalve, we look at PTTs. Is that part of the reason bivalve's been more effective? We're just monitoring PTTs?
One could argue maybe yes. And I've wondered that part of the success of bivalve was, at least for us when we first started using it with VADS, is that you really have to normalize patients' coagulation status and try to achieve a normal coagulation profile before initiating. And the first ways we were doing it is we were just going 1.5 to 2 times the baseline PTT. In Boston, for heparin, we've actually resorted back to monitoring with PTTs, because the reality is that the assays can be exquisitely sensitive to antithrombin 3. And so in order to achieve a therapeutic anti-10A level, the PTT correlate for a neonate with low AT3 could be a PTT greater than 170 for an anti-10A of 0.5. And so you get this big disconnect, which ultimately predisposes these patients to getting bleeding events. But I think the correlation of PTT to anti-10A improves as the patients get older, which is why in adults is a pretty similar dose response curve. But in our smaller patients that are deficient in AT3, you really see this kind of divergence in correlation between PTT and anti-10A. So at least in our cardiac ICU, we've shifted to using a PTT for heparin monitoring, because we have a predominance of neonates in whom we've struggled with either achieving therapeutic levels or overachieving with an anti-10A.
Yeah, and Kevin, you alluded to it, but anti-10A is essentially our blood concentration tests. And if you think about the bivalve experience, you may recall when you were here with us, in the early experience, we titrated to the dilute thrombin time. And what we really have learned is that the dilute thrombin time, from one of my figures I showed, that has the tightest correlation with the bivalirudin dose, but not necessarily the tightest correlation with the clinical effect. And so we've transitioned from titrating to the dilute thrombin time to titrating to the PTT, because the clinical effect seems to be with the PTT, much like what Christine had alluded to. And some centers on the call might have access to a bivalirudin level. It turns out actually a bivalirudin level is a conversion or a calculation from a dilute thrombin time. And so essentially those two things are akin to an anti-10A level, which is a drug concentration which may or may not have the same effect in one patient versus another. And so I think, I think what's old is new, and PTT is coming back. And I think PTT is probably just the more global assay and more effective monitoring test for both bivalve and heparin as well.
Thanks so much.
Awesome. Thank you, guys.
Thanks, Kevin. Well, thank you everyone for joining. I will send out the link to this recording to you all, everyone who had been able to register, since we've run out of time. And everyone, enjoy your afternoons. Thank you so much to the speakers. That was really, really excellent.
Thank you.
Thanks,
Thanks so
everybody.
much.
Thanks.
No.